Welcome to the Dr. Lexi Show, where I take pregnancy topics and break them down into simple terms to help you advocate for yourself and your pregnancy. I'm Dr. Lexi, a board-certified OBGYN and maternal fetal medicine specialist, which just means a high-risk pregnancy doctor. And today we have a wonderful guest with us who is a reproductive endocrinologist and infertility specialist. We like to call them REI doctors. Dr. Shane Lipskind. Welcome.
Thank you, Lexi. Appreciate the invite.
Yes, thanks for coming. I'm so excited to have you. So I always start out my my podcast with tell me a little bit about you. So can you tell us a little bit about you?
Sure. Yeah, absolutely. Yes, true. Reproductive endocrinologist and fertility specialist. I've been here in the Phoenix area now, going about almost 10 years in practice. I have a wonderful wife, Marissa, and two little girls, Francesca and Gianna, and they're both products of IVF. So I'm pretty familiar both on the professional and the personal side with these fertility-related topics.
Okay. I love it. So I love that you bring that up because we can then talk about maybe two sides of the coin.
Absolutely.
Like being the provider for reproductive technologies and then being a patient's significant other during it. And can you help us a little bit for the vocabulary surrounding infertility and reproductive technologies? So I use reproductive technologies sometimes because I think it's kind of a blanket statement, like assisted reproductive technologies.
Yep.
And then for the listeners, I wanted it to be broken down a little bit because we always hear IVF and we think any infertility issues, it's IVF all the way. And that's all the terms that we hear in the news. So can you just break down some of the terms of like, what are the things that people can do to help them get pregnant, including IVF?
Oh my, yeah.
So much time, right?
I want to start with terms first. So I think terms, I think you're right. Assisted reproductive technologies is more the blanket term, right?
Okay.
And it encompasses IVF, but ART, assisted reproductive technologies, is any form of treatment that involves manipulation of eggs or embryos outside of the body. Okay. IVF stands specifically for in vitro fertilization. Like you said, kind of gets thrown around a lot.
Yeah.
Sort of the blanket term in substitute for other forms of ART, even if technically in vitro fertilization is not being used. But that's what it is. In terms of things that can assist patients in getting pregnant, it's not IVF or nothing. A lot of times, patients that have infertility are going to get pregnant on their own. Just in a matter of time or through optimizing natural fertility or maybe, surgical correction of anatomical problems like polyps or fibroids or endometriosis. And then of course there's, lower tech treatments that also can be very beneficial. So if somebody doesn't ovulate, providing medications to assist them with ovulation or super ovulating somebody, giving them fertility medications to produce extra eggs and combining that with timed intercourse or intrauterine insemination, that's IUI, the other acronym that gets thrown around a lot. So there are a lot of different options that are out there. IVF is probably the best known, but it's certainly not the only one.
When you say that people come to you with infertility issues and some of them can still get pregnant on their own, generally speaking, and I'm sure it's different everywhere, but like, would you say it's half of the people, a third? How many that come to you, you're like, just if a gestalt, like what do you feel like the percent of those are roughly that you're like, they didn't need not that they didn't need your help, but they didn't need a bigger intervention. They just needed different counseling.
Yeah. I would say it's small, but not insignificant. Yeah. So literally every month I have a patient that I either see get canceled off my schedule because she called and got pregnant on her own, or we see them for their initial consultation and they technically meet the diagnosis for infertility, which we will talk about. Yeah. But then they complete their diagnostic workup and before they move into treatment, they achieve a pregnancy. Today, in fact, I saw one of my former IVF patients who has a 7-month at home and found out that she was pregnant on her own after going through IVF with very, very, low ovarian function and, not an easy IVF case. And it has surprise pregnancy 7 months postpartum. So it happens all the time. Yeah. Yeah.
Okay. And we're going to get into so many definitions. And before we do that, we're going to start with our questions that we have for all guests. The random questions.
The random questions.
Yes. Because I want to make sure we get those out of the way before we dive deeper into infertility, because that's where we're going to go straight after this is definitions and discussion of infertility, because that's what your job is based around.
Right.
Okay. All right. These are 10 questions, and just answer whatever. You probably will get all these right, which will be great. Question number 1. What does the abbreviation OBGYN stand for?
Obstetrician, gynecologist.
Correct. Question number 2. What do the letters MFM stand for?
Maternal fetal medicine.
Yes. And I know your letters too. We all have letters, right?
We do. We have to have the letters.
Do we get
The
it?
more after the name, the better. The more important you are, I think.
That's right. You just abbreviate everything too.
Yep.
Question number 3. How does a provider come up with a due date during pregnancy? And I can't wait for your answer, because it's you can be as medical as you want, and then also break it down, because yours could be so different from mine, right?
Yeah. So most of the time it's based off of a known
keyword
first day of the last menstrual period. Okay.
Yep.
But in our world, oftentimes it's based off a known date of conception, such as the date of ovulation, intrauterine insemination, or based on the date of embryo transfer. And if none of those things were known, then we would rely on somebody like you to a first trimester ultrasound, hopefully, and provide dating based on ultrasound.
There we go.
Yeah.
That's why I always like to share with listeners, like, this is not, if you're in a pregnancy and you're like, how do I not know my due date? It's not uncommon for someone that got pregnant naturally to have it's confusing, right? Like, and it could possibly change. It could stay the same. There's, all this back and forth.
It gets very confusing, especially with in vitro fertilization, because, you're thinking about it based on the transfer date. And at the time of the transfer, oftentimes you're basically already, quote unquote, 2.5 weeks of gestational age based off of this, how we conventionally, date a pregnancy based off the first day of the last menstrual period.
Right.
And so, it's really confusing.
Yeah.
You have an embryo transfer. Couple weeks later, or 9-10 days later, whatever your program does, you get a pregnancy test, it's positive. Now you're about 4 weeks, and then 2 weeks after, you're seeing a pregnancy in uterus with a heartbeat. It's crazy.
Oh my gosh.
Yeah.
You can tell, like, I'm seriously shocked with this, because although we both went through OBGYN training, we then took 2 different routes.
Oh, yeah.
And so, like, what he does just blows my mind, because it's not what I do at all. And people sometimes, when they come to me for like a preconception visit, sometimes it's due to infertility, but they're starting with me. And then their question is, so how are you going to get me pregnant? So I always try really hard to define my role and what I'm trained in and what I do, because I never want to start a consultation and someone think that I'm the one that will help to get them pregnant, because that is so far from the truth and not what I was trained in.
That's interesting. Yeah. I mean, that's difficult. And I have to be careful too, because, going through OBGYN residency, a lot of programs are OB heavy, and you do get more obstetrics exposure, but it's been years since I've managed obstetrical patients beyond the first trimester. Yeah. So, I know a little bit, but I always want to defer to the specialist in that area.
Yeah. No, it's so, it blows my mind too, when people go through medical training and you get to the end and you're like, a lot of us, you had to go through the same thing to get there, but you get so specialized and subspecialized. And thankfully, that's your little niche, right? I think that's where you live. But as a patient, I think I forget that as a patient sometimes too. Like when I see my cardiologist, I'm like, why aren't they telling me anything about my lungs? They don't listen to my lungs. They are like heart and I'm done, right? Like that's their area. So they, they stay in their lane, which is probably a good thing. All right. Question number 4. When is a pregnancy considered term?
40 weeks. Well, 37 weeks.
There you go. I'm so proud of you as an REA doc that you just correct. Yes. Okay. Question number 5. What is a normal fetal heart rate?
Varies depending on the gestational age of the pregnancy.
Correct, Mundo.
Yes.
Faster than ours though, right?
Yes.
Like, is that a good, okay.
Definitely
I love it. Question number 6. What is antenatal testing or fetal well-being testing? I'm pushing him because this is not his field.
Yeah, this is kind of mean. I look at antenatal testing as a method to assess the wellness of the fetus or the pregnancy. And for the most part, when I hear that, I'm thinking about ultrasounds. I'm thinking about non-stress tests. Methods to assess how the fetus is doing in the womb, if it's growing well, if there's any placental, insufficiency or issues with how the placenta is functioning.
Yeah.
If there's any risk for intrauterine fetal demise, if interventions aren't taken.
Yeah. I want people that are listening to understand this too. This is an insanely intelligent, well-trained doctor who can tell you right now that's a tough question, I think, because if someone says to a patient, you need fetal well-being monitoring, you had a lot to say, right?
Yeah.
Like it's not straight and narrow, because I think that's part of the problem with the communication that OB providers have with patients. It's you're going to do fetal well-being monitoring. That can look like so many things.
Sure. Could be kit counts.
It could be kit counts. Right. There's so many different things. And so that's why I have these kind of nice handouts that you guys can find online too that outline some of the words surrounding fetal well-being monitoring, the questions to ask, like, do I need it? That's the first question, right? Like, are we planning to do that? And then how does it look? Meaning, is it once a week? Is it twice a week? Am I going to a hospital for it? Am I coming to my doctor's office? Am I doing fetal kit counts at home in addition to what he mentioned, like a non-stress test or some type of an ultrasound? So many different ways to skin the cat, right?
We're going to get some more acronyms out of it.
And more acronyms. Absolutely. All right. Next question here. Question number 7. How does an ultrasound estimate the weight of a fetus?
Oh, so it's done through measurements, which they call biometry. So it's measuring various taking various measurements of different parts of the fetus's anatomy. So abdominal circumference, length, head circumference, femur lengths, all these different things. And somehow or another, the very smart computer comes up with an estimated weight based on that.
Yeah, I love it. Yeah. This is something that I think is hard to conceptualize too, because it's like, how are you weighing my baby? Like, how is it really a weight, right? It's not. We're taking measurements and then putting it into a calculator and getting a weight.
Okay, but you know what blows my mind?
Tell me.
These calculators are pretty accurate.
Yeah.
So when I do my ultrasound, my first trimester ultrasound on patients from their known date of conception, from their IUI or their IVF, when we're absolutely certain about, when they conceived.
Yeah.
The millimeter measurement down to the 10th is so scarily accurate for most patients within a population. It just blows my mind.
Wow.
It winds up being exactly on plus minus a day in 90+% of our patients.
That's fantastic.
Yeah. First trimester, but it's crazy.
And I saw something recently too, this just kind of off the cuff, an email I got, like when you're part of you get a journal or something and they send emails of like, here's a new article from a journal. Like, you probably delete them all because they're just like, they look like junk mail that comes in. And one of them was talking about some artificial intelligence that they're using to kind of do ultrasounds now to estimate the weight of the baby and to look at all the anatomy. So like, you don't even need someone there. You just have to have someone kind of do this. Right? Have you heard about this?
Yes. So they came out with something similar for ultrasound monitoring, follicular monitoring for fertility patients, where basically, you place a transducer vaginally and it kind of does like a 3D ultrasound, like sweep across.
Okay.
And it would visually represent all the follicles in different colors based on their sizes. And it would kind of automatically do that, average follicle diameter for you so that you didn't have to have a skilled sonographer to go through and measure every single one.
Wow. Are people using that in practice? That's not a standard of care, right? Okay.
No. I mean, I remember this was being kicked around when I was in fellowship more than 10 years ago.
Yeah.
I think that the technology is probably advancing and that there are some, companies that are still trying to implement it.
Sure.
And yes, there's a lot of talk about using AI, in this respect, as well as like monitoring and even making decisions about medication dosing and when to trigger a patient to take eggs out or to, do the insemination. So pretty interesting. I still think we have jobs for a little while though.
Yeah. Okay, good.
Just for a little while.
This is good.
Yeah.
This is good.
Yeah.
Thankfully. All right. This is one of my favorite questions here. Question number 8. What makes up amniotic fluid?
Oh. Well, I will say that some of it is going to be urine and dead skin cells.
Yeah, there we go.
Yeah.
I love it.
Yeah.
Don't you just love saying urine or pee? Like, it's that's what it is.
That's what it is.
And I always tell people too, I like seeing a decent amount of amniotic fluid because then I know the kidneys are working.
Kidneys are working.
And I like that. I like working kidneys.
That's right.
Let's do it. Question number 9. Who should be offered Down syndrome screening in a pregnancy?
Everyone.
Everyone. Thank you.
Yeah.
Yes. This is my favorite question, but I have multiple favorite questions clearly, but I think that's fantastic.
And the reason for it is because there are more Down syndrome babies born to women under 35 than over 35, because you have a lot more women under 35 that are pregnant.
That's right.
So everybody should be offered.
Yes. Thank you. And I've had people that are like patients or had been pregnant, and they typically start with women over 35 or at or beyond 35. And then I think everyone, because they've heard on the news and all this stuff, like, that the risk is higher. So like it gets put in our brains as women, like, I mean, if we're below 35, our risk is not that high, but the frequency is more common. Is that kind of the way you're saying it in a way? Yeah. Exactly. It can be very complex. I know. Statistics. That gets into statistics, and we're not going there today. Question number 10. What is considered a normal length of a cervix in pregnancy? Okay. And everybody, like, obviously you're a physician, so you're going to have a more like intense answer with more descriptions likely.
Yeah. So, fine.
Yeah.
I would say we definitely want it longer than 2.5 centimeters. To me, normal would, in an earlier pregnancy, would seem like 3 or more, 3 centimeters or longer.
Yeah. And I love that answer. Yeah. And the reason I bring that up is because it's now recommended that everyone who is pregnant gets, again, this is a blanket statement, not if you had a history of preterm deliveries that were due to preterm labor. This is a run-of-the-mill pregnancy, right? Everyone should get 1 cervical length during their pregnancy. And that's a new thing in our world of high-risk pregnancies that used to not be that way, because it was like, is it cost effective? Should we do it? And now it's like, yes, everyone should have a cervical length evaluation around 20 weeks.
But then the controversy is, what's the intervention after?
Oh, we have so many things to discuss with that, which we will not get to today.
Next question.
But yes, exactly, right? But yeah, Pandora's box, here we come. All right, so those were the 10 questions. Now you have 10 true, false questions, and then we're done with all these, I promise.
Okay. All right.
Okay, true or false? A fetus can have hair in the womb.
True.
Very true. Question number 2, true or false? A fetus can hear.
True.
It's just, you're 2 for 2. Question number 3, if a pregnant individual eats sugar, this will wake the fetus up if the fetus is sleepy.
Oh, I hear this all the time, and I'm going to have to say true.
Okay, so I'm going to say it's debatable, but data supports it being false because the sugar doesn't actually, it kind of puts babies like, people say I'm in a food coma. They kind of could be more sleepy after sugar. So another thing from some studies, when you give a pregnant individual steroids, like an injection of steroids, and a lot of people listening will know, like, oh, I got steroids in my pregnancy. I hear patients all the time, like, I got those 2 shots for the baby's lungs, right? Those can actually, you can see decrease movement sometimes in fetuses on a monitor because it kind of makes mom's blood sugars go up. It's a steroid, right? And so when people always say, oh, my provider, someone told me, or the internet told me to drink orange juice and a bunch of sugar, it will not wake a baby up. Babies do the sleep cycles. Sure. So, and it can sometimes make them a little more lethargic. Yeah, or not move as rapidly. Mm-hmm.
All right. Myth busted.
Myth busted. There we go. Question number 4, true or false? Everyone should be screened for diabetes when they're pregnant.
I'm going to go with true.
Yeah, I agree with that.
I'll go with true.
Question number 6, true or false? Someone with 2 prior cesareans has to have another cesarean.
Has to?
See, that's it.
No, but
there you go.
But probably will. If that's fair to say.
Probably will. That's right. That's right. And we've talked in the past, there's all these calculators online that people can go to on their own to see if they are considered maybe a candidate to have again, abbreviations that we love. TOLAC, a trial of labor after cesarean, to then lead to a possible VBAC, vaginal birth after cesarean. Can we just, it's just so many letters. So many letters. Question number 7, true or false? Twins that are the same gender are always identical. You say that like everyone should know that. Everyone's gotten that right so far, which I'm really happy about. Some of the people have gone through IVF, so I think that they understood a lot about things, but I think some people also have seen the movie Twins, and then they're like, oh, short and tall, and they don't look the same. So anyway, so while we're on that topic, to just divert for 1 second, and if this is too controversial, we can nip this in the bud and not talk about it, but if someone is undergoing IVF and they come to you saying, I want twins, how do you handle that? I'm so sorry. That popped into my mind of like, I so want to know what an REI doc would say to me about that. Like, I think it's interesting.
Yeah. I honestly probably answer that question at least every other week.
Okay.
So I tell people that twins should never be the expectation, and that if we are, we're going to do IVF, we're going to follow guidelines regarding number of embryos to transfer, and in good prognosis patients, that means one at a time. People have in their mind that IVF is associated with a chance for twins, which it is in any circumstance, even single embryo transfer, but much less so with single embryo transfer versus transferring multiple embryos. And essentially, the reason that IVF got this reputation was because in previous times, IVF was not as successful as it is now. We did not have methods to evaluate the potential for live birth for each embryo through its development to later stages in the lab, like day 5, day 6 blastocyst, or with doing pre-implantation genetic testing of the embryos to assess the chromosome makeup of the embryos. And so additional embryos typically were transferred to give patients a halfway decent chance that at least one of the embryos might be viable and implant. But now, when we have other methods for being able to assess the fitness of the embryo, we can transfer a single, either chromosome-tested embryo or top-quality blastocyst from a younger patient. We know that we're going to have very high rates of implantation. And if we put in more than one, we know we are accepting a significant risk for a multiple pregnancy. And I don't have to tell the high-risk OB/GYN that if our goal is to have a healthy mom and a healthy baby, and our goal is not just to say that we achieved a positive pregnancy test or a clinical pregnancy, but that we actually had a baby that delivered at term and was born healthy and alive, then, we know that the way to do this, the way to accomplish this most reliably is to do one embryo at a time and to give each embryo its best shot. And I think it's hard for patients that have struggled and are desperately wanting for one or more children to kind of be patient and, to see the forest beyond the tree. And so they just think, hey, if you put in 2, then that definitely is going to double my chances, right? But the reality is, no, it doesn't. I mean, at some point, you can't make your chance of getting that positive pregnancy test much higher, but you certainly can increase your complication risk and your miscarriage risk, your preterm delivery risk, your risk for gestational diabetes and preeclampsia and all those other things. And so when we have that real conversation with them, we tell them, look, I'm advocating for you. I want the same thing that you do. I want you to have a healthy baby in your arms at the end of this process. Most of them will, trust me on that and accept that that's how we're going to treat them. And I'm upfront with it because if somebody has a different expectation, I don't want to take them all the way through the IVF process up to transfer and have that be the time when we're having this difficult, sort of contentious conversation about, how many we're going to put in. So.
Yeah. And I love that you talk about the expectations at the beginning, right? And I think that that's such a big thing that patients have struggled with, and I've heard from friends more so, not even just patients, about we got down the road and certain things weren't discussed at the beginning, and had I known XYZ, I may have chosen a different path. Yep. So I love that you do that. That's fantastic. And for everybody who is listening to this and can't see the smile on our faces, it's about providers like Dr. Lipskind that do things like this and talk to patients at the beginning and help them learn how to advocate for themselves and just speak up and ask questions. I'm assuming you're a doctor who always, or at least most of the time, or tries always to let patients know, ask questions. Are you an advocate of bring your questions to me and I will answer them?
Yeah.
Okay.
I mean, and it's, it's funny. And there are some patients that always have a lot of questions.
Sure.
And, I appreciate that. I mean, I think most of us that went down the pathway into medicine are fairly type A and like to research everything. And,
we're organized. We're organized.
So when somebody brings out the tabbed notebook, I know I'm in for some good questions.
And I respect that, especially if it's color coded.
Yeah.
those are my people,
Yeah.
right? You have like staples here and little paper clips, and
It's great.
Yeah, it's
It's
tight.
great.
I love it.
But even better is if you anticipate those questions and you ask, do you have any questions for me? And they say, no, you answered them all already.
Yes.
That's the best.
That's my favorite. And I actually talked about that before. Is like, I had to also say at the end of visits, I used to say, do you have any questions? And I realized that's such a vague way to ask someone if they have questions. I would always say now, like, do you have any questions about what we talked about today? Little summary of what I discussed, or your follow-up plan of care. Because that's what I'm talking about. So sometimes when I say, like, do you have any questions? It's like, yeah, so my sister, seriously, my sister's pregnant. And so she had this happen. What should she do? Right. And I realized I opened that door. I said, do you have any questions? Right. So like, I love the clarity of questions too. And I do love it when a patient's like, no, you got every one of them. Like preemptively, if we can think about the questions, it's like, yes, it's like the best. And before we finish these, and I want to, you mentioned embryo and blastocysts. So those are not abbreviated. We get the full word. Can you give us just like a definitions, or what's the difference between an embryo and a blastocyst?
Oh, I gotta add one more in there.
Yes.
It's the egg too.
Oh yes, add the egg.
Every time I find patients and even us, we're like switching back and forth between egg and embryo. So,
Yeah.
the egg or the oocyte it's the unfertilized egg. There's been no sperm contact.
Yep.
It's not fertilized. It doesn't have.
It's alone.
It's alone.
It's alone. It's a lone egg. Okay.
That's correct.
Okay.
And then the embryo is any fertilized egg. It's any fertilized egg. And it can be from a single cell zygote, day after fertilization, to a cleavage stage. We call it day 2 or day 3 embryo, to the day 5, day 6 blastocyst embryo. And the blastocyst, sometimes we'll call them blasts.
That sounds so cool.
Sounds cool, right?
The blast.
Blasts. How many blasts did you get? Yeah. How many blastocysts did you get? It's named for the blastocele cavity, which is just a fluid-filled cavity within the embryo. I mean, this embryo has 80 to 100 or more cells. Typically, it's going to, you got to think about it as like a three-dimensional, almost like a beach ball. It's going to have a lot of cells, and it's going to be filled in the middle where the air is, and the beach ball is going to be filled with fluid. And the cool thing about the blastocyst embryo is that it's started to differentiate its cells into a part that will become the placenta, we call the trophectoderm, and then the part that will become the baby, we call the inner cell mass. And so you can actually see those under the microscope. And if you're going, and they're graded.
This is so cool.
Based on how they appear, how the cells appear, there's a subjective, sort of grading system.
Like whether they're good or bad, kind of.
Yeah, and they give the A's and the B's.
Okay.
But they grade them based on how they appear microscopically, and give the 2-letter score, the AA, the BB, referring to the trophectoderm and to the inner cell mass grades. And then they also, if we were to do the pre-implantation genetic testing on the embryo, it's that placental part, the outer cells, that outer edge of the beach ball that the biopsy comes from. And they usually remove about 5 cells for doing the genetic testing on the embryos.
This is under a microscope.
It's under a microscope.
So I want people to understand, like, when you're talking about cells, it's not like he's like looking at it with the naked eye and is like, I'm going to take these 5 cells. Like it's someone putting, do you do this, or is there an embryologist? Okay. See, this is, the embryologist is looking under a massive cool microscope and poking into, right?
So
how does this happen?
Yeah. So what they usually do is they use typically laser now to create a hole in the protein coat or shell that starts around the egg, and within which this embryo has been forming for the last 5 or 6 days. And they hatch it. So they make a small nick in that shell with a laser. And then what will happen is that embryo is expanding within the shell. Some of the cells will start to ooze out from that hole, and they'll hold and stabilize the embryo with one microinstrument, and then with another, they'll kind of tease some of those cells away from the embryo, and they'll use the laser to go between the cell junctions and to remove those 5 or so cells that they want to remove for biopsy. So yeah, it's really cool to watch.
Yeah.
There we do have, I mean, there you can internet search for videos of it. And we have some videos of this on our website too. Yeah, it's very, very interesting.
So you mentioned pre-implantation genetic testing.
Yep. And
so I feel like when I see patients who have undergone any type of assisted reproductive technology and they say, they usually say we selected eggs. They say eggs sometimes, right? Where the embryos that we used, they were tested and they're all normal. So if you had a patient coming in, I guess, to you later and you're like, yeah, and they say to you, I told my OB provider that all the eggs are normal. How do you address that term normal? Like, because that's a phrase I hear all the time.
Oh, that's a great question.
It's a great question, right?
It's a great question. I think normal makes sense to a lot of patients. I think it's fair to say that the result of the biopsy was normal. Mm-hmm. It was euploid. It was chromosomally normal. But really, if we're going to be very, very, strict and technical about it, we still regard pre-implantation genetic testing as a screening tool, as a tool for prioritizing your embryos for transfer into either low risk or high risk. And it's very accurate. I mean, the diagnostic accuracy of pre-implantation genetic testing is very high. But, we have unrealistic expectations for tests in medicine, and nothing's 100%. So, most of the PGT laboratories, they will tell you that their results can be relied on with 98, 99% confidence.
Yeah.
And that matches my clinical experience with it too. But it's important that patients understand that there are both false positive and false negative tests. And, if we are assessing an embryo from a biopsy of just 5 of the cells from this entire embryo that has, 100 plus cells, is there any circumstance in which the biopsy result could be wrong, either from a technical issue, from mosaicism, where there's a mix of normal and abnormal cells within the embryo, or from, a laboratory error? I hate to say it, we don't ever have any of those, right, in our program. But if there was a laboratory error and the wrong embryo was transferred for some reason. So, you do raise a very good point. And a lot of patients ask me as we're kind of, getting to that, 8-week, 10-week mark, and they're getting ready to transition over to their OBGYN. They ask me, should I do non-invasive prenatal testing? Should I do first trimester screen? Do I need to have an amniocentesis? And I say, I think you should do all the routine, testing with your OBGYN. Anything that would be recommended otherwise, I think you should do, because there's, an opportunity, number one, to screen for things that are not related to abnormal chromosomes, whether it's abdominal wall defects, neural tube defects, anatomical problems. Thickened nuchal translucency can be predictive of pregnancy outcomes regardless of chromosome issues. So I do encourage patients to do the testing, that's recommended with their OBGYN, even if they have transferred a quote unquote normal embryo. Yeah. The cool thing though is that we know if they transferred a normal embryo or euploid embryo, that it's almost always going to be a normal, chromosome sort of aneuploidy screening result, right? And so it alleviates a lot of anxiety there.
Yeah, and when they're doing the screening on that, I know that there's the PGT for pre-implantation genetic testing, then you can get the hyphen at the end, and then it's like A for aneuploidy, right? So that's aneuploidy is like kind of a chromosomal type screen. Can you clarify a little bit what chromosomes would you be able to say to a patient that PGT aneuploidy screening is actually screening for?
That's great. So it's actually looking for the presence or absence of all 23 chromosome pairs.
All 23 chromosome pairs.
23 chromosome pairs. And this is modern PGT. Yeah. Back in the 90s when this came out, they were only screening for a limited number of chromosomes in a day 3 cleavage stage embryo. And now it's comprehensive chromosome testing, all 23 chromosome pairs from a blastocyst embryo. So it's just a night and day difference in the technology and how well it works.
Wow. So I love that you said as well that when they become pregnant, cell-free DNA or non-invasive prenatal testing, which is in my wheelhouse of like the blood testing that we do to screen for concerns for really just the 3 most common chromosomal abnormalities that we might see. Trisomy 21 or Down syndrome being the most common one, and then trisomy 13 and trisomy 18. So when you come to an OB provider and we talk about screening, we're only getting a few, right? We're just looking at the 3 main ones. Now, your provider might talk to you about doing some expanded cell-free DNA screening or non-invasive prenatal testing, which could include things like DeGeorge syndrome and monosomy X, which is Turner syndrome. But the data behind those items is not as good for the screening of the main 3, the 21, 13, and 18. So that's why I always try to bring up with anybody, if your provider is sending a screening test specifically with regard to Down syndrome or chromosomal things, ask what it's being sent for.
That's a great point.
Right?
Yeah.
And I talked the other day about this. I had a result come back recently for cell-free DNA screening. I didn't send it. Someone else sent it. And they came in as a referral for abnormal, air quotes here, abnormal cell-free DNA screening. Everything was positive on that test. Everything. Trisomy 13, 18, 21, monosomy X. And then it said monosomy 13. It was just like, which I've never seen that sent on cell-free DNA screening, neither here nor there. But that was the weirdest thing I'd ever seen. And I was like, okay, so I talked to the genetic counselor. And as we tell people, if you get a test sent like that, it's taking mom's blood, right? You guys are sending a biopsy from a small portion of the balloon or the beach ball, right? Right. And we're taking mom's blood and spinning it down and trying to get this fetal fraction thing. So this patient, lo and behold, had a mass in her breast and is being worked up for breast cancer. And so that's one of the things that you'll see is sometimes these tests that are being sent can be flags for other things that don't even involve the fetus itself. So if you're getting a test sent for quote unquote Down syndrome, which now people just say, I'm getting the gender test. I mean, for those who didn't go through or know what the gender is or anything like that, they get this kind of thought of it's just testing the gender for my baby. So anyway, that's, again, we got off on a great tangent there, and I love it all. But I do love that you're asking them to, yes, still think about getting the testing, because from the Society for Maternal Fetal Medicine, that is a big recommendation, like even if they had it. Because I think, too, part of it is if a patient tells me I had everything done and it's normal, I might not have the records. That happens a lot, right? And so I'm obviously going to request records, but what if the testing was done for a single gene mutation type thing, something more specific, and not the aneuploidy stuff? So maybe trisomy 21 wasn't included in the screening test, right? There are just so many terms, right?
Well, okay. But now I have to ask you,
yes.
I'm going to grill you and put you on the spot.
Okay.
So
go for it.
If somebody comes in and they've had pre-implantation genetic testing with their REI.
Yes.
What screening method are you likely to recommend for them? Are you going to tell them to have a diagnostic amniocentesis?
I would recommend, if they're going to do any type of screening with a blood test, specifically for Down syndrome and then trisomy 13 and 18, cell-free DNA screening, just because it's a better test. We know the sensitivity, specificity is better, the positive predicted value is better. So for listeners, it's like if the test comes back positive, a higher percent that the test was truly a good test, meaning that the outcome would likely be what we say the concern is on the test. So I would recommend that as early as 10 weeks. Some data says you can go down to 9 weeks. The problem is that fetal fraction number that I was mentioning earlier, where you draw mom's blood and spin it down, the fetal fraction increases. And so it's still oftentimes low in people that are like 9 weeks. So when people are like, well, oh, somebody told me I could get it done in 9 weeks. Well, you can, but you might have to have it repeated if that fetal fraction is not high enough. So I would say starting at around 10 weeks, cell-free DNA screening. Nuchal translucency at 12 weeks, roughly around 12 weeks, to check the thickness of the back of the nape of the baby's neck, because that can be predictive of things other than chromosomal issues, things like heart defects, even for increased risks of miscarriage too. And then after all those results come back, discussing the option for invasive testing, which could be a chorionic villus sampling or an amniocentesis. And that depends on your gestational age. So once you're past 14 weeks, you got to, the gray area for those options is the 14th week. If you're within the 13th week, it would be the CVS or chorionic villus sampling. If you're after 15 weeks, amniocentesis. Everyone is recommended to be offered the opportunity for an amniocentesis. And for those listening too, you might be like, well, if everything's normal, again, that term normal, with my screening, why would anyone discuss an amniocentesis? And I'll give you the example of you have to think that the rare chromosomal abnormalities in a pregnancy, the age doesn't change, meaning the age of the person that's pregnant, that risk of a rare chromosomal abnormality is always about 1 in 270. The risk of things like trisomy 13, 18, 21 that are more common, those are going to be increased with age, with maternal age. But the super rare ones, these microdeletions, the things that we can't pick up, those are going to be the same risk stratification for every age person. And that's why when we say everyone should be offered an amniocentesis or invasive testing, it's to try to look for a full chromosomal microarray. So we're not just looking at the big chromosomes and the numbers of them, we're looking at the details within the chromosomes. And then you get into like insurance. Will it cover it? Will it not? Is it going to pick up everything? No, it's going to pick up microdeletions, some bigger macrodeletions, these things, but it won't pick up everything. And that's what I struggle with, is like if I offer that to everyone and that comes back normal, there still is a possibility that something else could be going on, right?
That's hard.
It's very hard. It's very hard. I have a friend that just had a baby recently and everything went normal with the pregnancy, and then the child wasn't standing well and sitting and meeting milestones. The muscles weren't really, developing well. And then they did some genetic testing directly for the child and found a small microdeletion. That there, no way that would have been picked up. An amnio could have picked it up if you sent the amniotic fluid for the right thing.
Okay.
And that's the problem, right? Is like, if you don't see that something's wrong, would you really choose to spend the extra money or do more testing if you don't physically see anything wrong?
Right.
No,
I know
it's hard.
I wouldn't.
No, most people, yeah. And so I think, then we get to the point now where they have full exome sequencing, right? And so you're doing another level. And apparently right now the cost of that is $5,000 to $8,000. And that's just like, whoa,
Yeah.
So all over the place. I know.
Okay.
It's expensive to be pregnant and to get pregnant.
Yeah.
All right, let's see. Oh, this is a great question too. True or false? No cheese is safe to eat while pregnant. False. I love it. Eat your cheese. Eat your cheese. Eat your cheese. Eat your pasteurized cheese.
Yes.
Let's clarify that. Question number 9. I do have a really good YouTube on cheese, and it goes into listeria because I think you need to know what listeria is. It's a good idea. It's a good idea. And also be careful with your lunch meats. That's the other thing that I said.
Can you microwave it and then it's okay?
You're supposed to get it up to a certain degree of heat. And I believe in Fahrenheit, it's 160. I'm terrible with math and numbers, but it has to be above a certain level, i.e. the data says it should be steaming. So if you like a steaming hot sandwich, then you're good to go. Perfect. Who doesn't want that? Question number 9, true or false? Someone trying to get pregnant should start folic acid before pregnancy.
True. 3 months before, please.
Yes.
Thank you.
Yes. You're welcome. You're welcome. I did read this recently. I've talked about this a couple of times. Did you know that there are birth control pills that include iron for sure, right? But some of the birth control pills now actually have folic acid in them.
I was not aware, but I like that idea.
Right? Yeah. Because then when you stop it, or if it didn't work for you, then you're like chugging into this pregnancy already having some folic acid on board. Love it. Yeah. Last, true, false. Baby aspirin is an over-the-counter medicine that can prevent a certain type of high blood pressure during pregnancy.
I would say true.
I agree with that.
True. Yeah.
Now that's going to take me into the question of when you're talking to people that are going through some type of assisted reproductive technology. So they're at the point where they're like, yep, we've tried all the things naturally or as natural as we can. Yep. And we're moving towards something that's ART now, right? How much of a role does aspirin play in that trying to conceive time in your world?
Oh, that's such a good question. I think aspirin use is very, very prevalent in the fertility world. And I would say most of that is without any good evidence to back it. That's fair to say. I think it's part of our voodoo that a lot of people trained, with, we're going to give aspirin. It may help improve blood flow to the implanting pregnancy. If there's any tendency toward, blood clotting that could interrupt blood flow, then this might help. So we frequently encounter patients that are taking it or we recommend it. And I mean, it's, as you know, I mean, if you just did a lit search on aspirin and look at any number of different, medical conditions, you're going to find studies that are out there, whether it's for prevention of preeclampsia, prevention of recurrent pregnancy loss, for thin endometrium or thin lining of the uterus. We kind of see all of these areas where aspirin has been under investigation. And with some of the studies showing perhaps positive benefits and others not so much. But where I kind of come down on this one is, in general, if somebody doesn't have aspirin allergy, they don't have upper GI bleeding, ulcers, things like that, I think it's reasonable to do. It's inexpensive. It seems like it has a reasonable safety profile. And for some of those conditions, it may be useful. So if people are taking it and want to take something in addition to a prenatal vitamin as they're going through their fertility journey, I'm fine with that one. I'm also fine with vitamin D, extra vitamin D supplementation, and coenzyme Q10, just some pretty simple over-the-counter supplements that, seem to have at least some data, showing that they may help support ovarian health and egg health. So
nice. Yeah. I love it. And what would you say, I guess, to people, I've had some friends too, who are like, we've been trying to get pregnant for a certain amount of time, and they had troubles talking to their OB provider and getting referred to someone like you. So could you kind of talk a little bit about when is it the right time to see you, and how would someone advocate for themselves to their primary care or their OB provider to gently nudge and be like, hey, I think it's time for me to see the next level of a person here,
Yeah, that's a good question. It kind of comes to just when do we have a diagnosis of infertility or suspect that there may be a problem? And first and foremost, we diagnose infertility as 12 months of trying to conceive without a successful pregnancy. And that's for women under the age of 35. If you're 35 or older, it's 6 months. And that's a nod to, sort of the shorter run ahead, and that there's a higher incidence of infertility and probably a greater probability that there might need to be some assistance. And so just...
Now, when you say trying to get pregnant, is there a definition within that of like, you have to be having intercourse at least on a weekly basis? Because it could be 6 months for some people could be, we had sex 3 times versus it was every other day. So the quantity of, the amount of intercourse is different. Does that play into the evaluation, or someone's like, listen, man, we've been trying for every day for 4 weeks, 4 months, whatever. And I think that should qualify me.
All right. I mean, it plays into the thought process. Yeah. It definitely does. So yeah, I mean, I certainly have patients that their frequency of intercourse is really not adequate for them to have, reasonable chances for getting pregnant, within that 6 months to 1 year. And that may be either just because of their practices, or, their schedules. I have, some patients whose partners are frequent travelers for work.
Yeah.
It just so turns out that almost every time it's that ovulation time.
They're not here in town.
They're not in the same place. Yeah. So that can happen. And, if they're trying to get pregnant, that still is kind of a fertility issue, right? So maybe the fertility specialist can help make sure, everything is otherwise okay, and maybe help them with that timing, or perhaps, have sperm banked and frozen ready to use if somebody's going to be, away. So there's some things that can be done there. But as far as advocating for oneself, I mean, I think, that duration of infertility, that duration of not preventing pregnancy, which is really what it is, because people will say, well, we haven't been using any contraception for the last 5 years, but we've really only been trying for 1 year. And, but were you having sex before? Yeah. Okay. There's still probably, that actually throws a flag up for me that there's probably is some more infertility there than they really even feel or know about at that point. So I think if you fall into that category of not preventing pregnancy for 6 months or longer, if the female partner is 35 or older, 12 months or longer, if the woman is under 35, or there's just any other known potential reproductive issue at play. Now, for women, I think it's really important to understand if you are not getting a period every month, if you are not, it doesn't have to be like clockwork every 28 days, every 30 days, but if you're not getting a period roughly every month, you're probably not ovulating regularly. Yeah. So don't waste your time. Your menstrual cycle is a vital sign for your reproductive health. You want to get that evaluated and figure out what's wrong. It could be something hormonal, something that can be addressed and corrected with simple medication, lifestyle changes, but it's going to be very challenging for anybody to get pregnant if they're ovulating infrequently, and virtually impossible, right, if they're not ovulating at all. So that's important. If there's any known history of reproductive tract disorders, such as fibroids, endometriosis, even suspected endometriosis, very bad pelvic pain, and painful periods, might make me think about starting an evaluation for somebody sooner.
Yeah.
And on the male side of things, there could be some clues there too, whether it be delayed puberty, a history of an undescended testicle, history of pelvic surgeries, testicular trauma, testosterone use, which is a big one that we see these days. So there are reasons where just by history, you might say, hey, I think I might need to see a specialist sooner rather than later.
Yeah.
And as far as asking the primary care or the OB for that referral, I mean, I think having a conversation with them would be helpful. Here's the thing. I think that a lot of primary cares and OBs are put in a really unfair position. They see so many patients. They have such a short amount of time to do it. And I mean, how much REI exposure did you have during your 4-year OBGYN residency? 1 month, 2 months, 3 months?
Maybe.
If you didn't get pulled to cover some other service.
Yeah, true. Very true.
So, I mean, there are a lot of really excellent OBGYNs out there, but they don't have necessarily the time to sit down with you and dive deep into an infertility history or diagnostic evaluation. And they probably didn't get a lot of extra training in it during their general education. And so, I think asking for the referral is very appropriate. And if you're not referred, most fertility practices will still see you without a referral. And obviously, some insurances do require it, but most probably don't, at least from what I see. So, feel free to be proactive and to, contact a board-certified reproductive endocrinologist if you think you need some help.
And it sounds like, too, I love what you said, too, about if you know your periods, if you go into your OB provider, your family care doctor, and you say, I want to get pregnant, they'll be like, oh, okay, give me some time. Right. But if you go in and say, hey, I would like to get pregnant. I've been trying for this many months, this many years. I have not been on birth control. I have been on birth control. Here's my period log, right? You can keep it on your phone now, too. There's so many apps and stuff. Being proactive and at least going in with those questions can really maybe speed that process up just by choosing the way in which you ask the question and present it with the data you probably have. And you just might think, oh, they'll ask me those questions if they want to know. Feel free to present it to them, right?
I think that's a great idea.
Yeah, I love that. I love that. Well, I always ask everybody if there's any, part of my whole concept here is about impact and trying to see, my whole point is to have an impact on individuals and help get information out there and help them advocate for themselves and hear from providers and know, we're busy, but we want to hear your questions. We want to do the best we can to provide information for you. So if there's anything you could share with patients, I guess I would say, or anybody out there that would be listening about what kind of impact that you can have and that you do have on your patients with what you do, how would you or what would you share with them?
Impact that I would have on my patients?
Yeah. And I've talked to people about this too. I feel like impact is this great word. You see it in commercials all the time, and it's such a strong word. But then when you say what impact, right, it's a hard question to answer, I feel, because it's you might not know the impact you had on your patients, but what impact do you feel like you're trying to have? I feel like we do this because we want to have a positive effect on someone. And that's the definition of impact, right? Yeah. So that's part of my expand knowledge, develop skills, impact lives. And the impact lives, I have troubles verbalizing it sometimes because I feel like it's what I want to do. That's how I would describe it. So I don't know. I just always ask people what is it that you feel like you do for people? Because I can tell you how I think you impact people because I see their smiling faces when they would come to me and they're pregnant and you had a part in that,
Well, it's extremely kind. Yeah. I mean, that's the obvious one, right? If I help them to grow their family and have a child, it's just world changing. It's life changing. And there's no greater joy than, having that patient, realize that dream of theirs. I mean, it's tremendous, but I think, it's not everybody sees me to have a baby. Number one, Not everybody that does see me to have a baby gets there for whatever reason. I mean, there are some cases of infertility that are just that hard or circumstances that are just that difficult where it doesn't happen. So I think, where we make an impact is, we really want to empower our patients. We want to educate them. We want to, put everything that we have at our disposal in terms of our medical knowledge, our technologies, and our ability to support them, emotionally through this very difficult, journey in their health. I think that's where the impact comes from, because you can be as technically amazing as anybody out there in the world, but if you don't help the patients, to rise to that challenge and to educate them and to help them be comfortable, help them understand, and to make good choices for themselves, whether it's, hey, I have polycystic ovarian syndrome and I need to, I need to really work on my diet, in order to start ovulating, or I smoke and I really need to, stop doing that. Or, I'm going to help guide them toward the most effective fertility treatment so that, they don't get worn out over the next 3 to 6 months of doing something that maybe wasn't the absolute best choice for them. And then they drop out of care altogether. So, it's empowering, it's educating, it's, being an advocate for them, with them, basically just really being on their team. The babies are amazing. That's the end goal for a lot of our patients. And, it's extremely gratifying to see people realize that dream.
I love it. And thank you for everything that you do for the community, for the patients, for the high-risk pregnancy doctors who need your guidance along the way with, and for handing those patients over to us in like a nice, pretty package too.
I try.
We love that. Thank you for coming today. I really appreciate it. Yeah. And for everybody out there too, don't forget what our goal is here, expanding our knowledge, which we did today. We talked about tons of definitions and abbreviations, which there are so many more we didn't even get into. And I'm so glad that we talked about a blastocyst today. And I will never forget the beach ball analogy in my mind forever. We developed skills, how to ask questions. You can always go online too and get your advocacy handout. It's an advocacy assistant. It's at drlexihil.com/advocate. And you can print that off, take it into your office when you're visiting with your OB provider, when you're pregnant. And there's just some 13 good questions to ask to help you learn how to advocate for yourself. And then we impacted lives, we hope. Today, we have gotten some of our message out there just talking about items. And that's one of the places to start, is just getting a little bit of the word out there that we as providers are here to talk to you as a patient, and that we are here to try to help you advocate and advocate along with you as well. So anything else that you can leave for comments, feel free to do that. Any topics you want to hear about, any guests you want to see, let me know. And as always, I'm Dr. Lexi, wishing you a happy and healthy pregnancy.